Josh, you want me to go ahead with the introduction? All right. Well, welcome everyone to the InCHIP lecture series. Thank you for joining us today. I'm very excited to introduce Dr. Marya Gwadz. Dr. Gwadz, excuse me, is currently the Associate Dean for Research, Professor, and Director of the Intervention Innovations Team Lab at NYU Silver School of Social Work. She also serves as the Associate Director in the Transdisciplinary Research Methods Core in the NIDA-funded Center for Drug Use and HIV Research at NYU School of Global Public Health. Dr. Gwadz earned her Ph.D. and master's degrees in clinical psychology from NYU. The main focus of her research is the development and evaluation of social behavioral interventions to address racial, ethnic, socioeconomic, and gender inequity in health. She has completed considerable work with vulnerable adolescents and adult populations that has included a focus on substance use, populations with high rates of criminal justice involvement, residentially unstable youth, and racial ethnic diverse populations living with HIV. Um, at the end of Dr. Gwad's talk, we'll definitely have time for questions, and you can either raise your hand or enter it into the chat, and I'll be moderating that session or that part of the talk. So please join me in welcoming Dr. Gwadz.
Thank you so much, everybody. It's such an honor to be here for World AIDS Day. And, I'm such a big fan of all of your work. So it's great to be among friends. Wanted just to start with, I guess it's a kind of disclaimer. The work that I do is focused on inequality, and that's brought us to racial and ethnic disparities. But I want to acknowledge I do approach the work from a place of cultural humility as a white person with privilege, and I hope you hear that throughout the talk today. So this talk was an opportunity for me to sort of take stock where I am personally in my work and where we are as a field in our work. So we'll talk a little bit about what we've learned, and I would say some gaps, errors, and mistakes that I've made and we've made in our thinking, methodological and theoretical innovations that we can take advantage of, and then future directions to end the epidemic. So the talk will focus on the experience of long-term HIV survivorship, and we'll talk a little bit about critical race theory and the HIV care continuum, questions we have about stopping and starting antiretroviral therapy, HIV and COVID, and we'll talk about the multiphase optimization strategy. So taking stock. I was talking to someone today who's a bit younger than I am, just about what it's like to have been working in HIV since 1989. It's been an honor and a privilege, almost a miracle, to see how much progress we've made in medications, their efficacy, their tolerability, interventions, healthcare system interventions. But at the same time, we have very serious and persistent racial and ethnic disparities. And then in light of the progress that we've made, we have sort of a new thing that we have to start thinking about, which is long-term HIV survivors. We started out in this field not knowing that that would be the case, and we're grateful that it is the case, but it's challenging us to evolve as a field and as a profession. And we have successes, and I think we often focus on those, but we also have some gaps. So the HIV care continuum focuses on people achieving viral suppression, and that's great, but we also need to see people sustaining viral suppression. And these figures show us that it's hard, and depending on your racial and ethnic group, can be very hard. So the questions that guide our group, we call it the IIT-Lab, are about stopping engagement along the HIV care continuum. What are the multi-level factors that push people off the care continuum? What multi-level factors bring people back on? What helps people sustain or persist on antiretroviral therapy and in care? And then how can interventions support engagement along the HIV care continuum? We'll talk about these questions today. Another sort of driving question in our work is, why are things the way they are? Talk about that today. So we have a very talented medical anthropologist on our team named Rob Freeman, and I hope he's on the call. And a few years ago, he came to us and said, let's use critical race theory as a way to sort of examine how people see engagement along the HIV care continuum. So the answer was yes, and it's a great way to learn about critical race theory. But here's sort of critical race theory, which is in the news these days, which is kind of hilarious if you really think about it, that a theory is so controversial in the news, and also people who don't want people to use critical race theory. Thank you for raising the profile of critical race theory by doing that. These are the primary tenets of critical race theory, that racism is ordinary, which makes it really hard to study, actually. The system serves the dominant group. Race is socially constructed, and then the social construction is the way that people of color are ordered and constrained in society. That's very relevant for people with HIV. Identity is intersectional, we know that, and the perspectives of the non-dominant groups are prioritized. The perspectives of the dominant group actually are prioritized. So in terms of how we apply critical race theory to behavioral science, in our work, we focus on racism, not race, and structural racism, not just experiences of racism. We center the margins, which means we focus on the populations that have the greatest barriers to the health outcomes. So our work focuses on African American and Black and Latinx populations. We attend to counter narratives. So counter narratives, another way of saying it, is conspiracy theories. Conspiracy theories, though, suggest that there's something wrong with those beliefs or that they're not grounded in reality. Counter narratives honors the fact that there are truths to the beliefs, and there's reasons that people believe them. So counter narrative could be something like that HIV medication is toxic, and that HIV was constructed in the lab to kill Black people. So I don't believe that HIV was created in a lab to kill Black people, but I don't argue with people about that belief because I could certainly understand why someone would think that given our society. So in terms of critical race theory, we also look at how people are ordered and constrained, and we pay attention to intersectionality. So what's structural racism? It's the macro level systems that reinforce inequities in racial ethnic groups. It's not that easy to recognize, but it's actually incredibly powerful. So here's a quote that sort of describes structural racism in New York City. The realities of separate and unequal are everywhere. Commuting times, pensions, proximity to banks, reading and math scores, dropout rates, school segregation, obesity, asthma, cancer, teenage pregnancy, breast cancer, drug arrests, reliance on unlicensed caregivers, makeup of the foster child population, incarceration, victimization by crime. These are sort of mixing causes and consequences of structural racism, but you could actually go on all day. I mean, this to me is very striking, but you could go on all day about the ways that we have structural violence and structural racism and structural inequality in our society. So how are we doing in HIV research with respect to understanding race, racism, and structural racism? When this epidemic started, it was primarily people who inject drugs and same gender loving men who are mostly white. And now most people living with HIV and who become infected with HIV are people of color. So we need to attend to that fact. So how are we doing in terms of understanding race and racism, structural racism? Not good, we are finding. So this is an important paper by Castle. Across numerous articles in public health research, terms racism and systemic racism are largely absent. And then looking at our field, HIV interventions, adherence research, this is looking at cultural competence, which may be sort of one manifestation of attending to these factors. Not good. So they ranked a bunch of interventions on a cultural competence score, and the range was 0 to 20, and then the median was 2.5. We actually got rated. We got a 7. I actually thought that was a little low, but it was definitely, at least it wasn't at the lowest end of the scale. So here's a paper on critical race theory led by Rob Freeman. And the sample was 37 people living with HIV who were not virally suppressed at the time they entered the study. And they have a lot of indications of socioeconomic disadvantage. And they'd lived with HIV for quite some time, almost 14 years. So what did we find? It was a qualitative paper. So the first theme that we want to emphasize in this work is that Healthcare settings are experienced as overly institutionalized by this population, and that is not a good thing. So the settings are experienced similar to other institutions that people from low socioeconomic status backgrounds engage with: criminal justice and housing support. And as a result, the settings emit what someone called invisible hostility. And that can be very degrading and demoralizing, and then also interact with sort of distrust, and then creates a lack of motivation to engage with their healthcare providers. So here's a quote from a participant. "I felt like just something invisible was speaking to me, that the furniture was run down. The receptionist just seems caught up in a sense like people needing a vacation." That's one factor that contributes to disengagement along the HIV care continuum. The second theme is distrust. So we all know that distrust exists in populations and plays a role in poor engagement along the HIV care continuum, but qualitative research is useful because it sort of allows us to understand the mechanisms of action and understand people's experience about it in a little bit more detail. So one interesting thing about distrust of antiretroviral therapy and HIV care for this population is that it's related to United States history and current day structural racism, but it's also related to the history of HIV. So HIV has its own history, partly true and accurate and factual, and partly counter-narrative, I would say, but still true if it's a counter-narrative. And one of the main threads in this is the history of adverse effects of early AZT monotherapy. So people know this. They will say in the early days of the medication, they were experimenting on us. Okay, it's partly true. And people took AZT and they turned gray and they died. And I'm really afraid of these medications. And partly it's because of these bad things that happened in the past. But the downside is that counter-narratives are not easy to discuss in healthcare settings. And you can feel the frustration from participants. They want to talk about this, and if they mention it anywhere, they're corrected. Well, they don't need to be corrected, but they do need to be listened to, and they need to unpack these counter-narratives, and they need to be able to discuss them openly in healthcare settings. At the same time, people do engage in healthcare and take antiretroviral therapy and hold counter-narratives at the same time. They're not monolithic. People can believe them to a certain extent. So what they basically doing is experimenting. They don't have it, antiretroviral therapy, correct yet. That's why they've made so many different types. Sometimes it makes me feel like it's not worth taking. Antiretroviral therapy has changed. Our guidelines have changed. We used to hit early, hit hard. Then we waited till T cells were 500, then 350. And now we again recommend medication from the day of diagnosis, but that can contribute, those changes can contribute to distrust, and it's hard for people to talk about. So the third theme is that patients are excluded from the health decision-making process. They're not treated as experts on their own health, and this is very, very, very frustrating for people. And not being treated as an expert and not having autonomy supported resonates with the history of medical maltreatment of people of color in our country. And it contributes to disengagement from HIV care, and because it doesn't preserve dignity and autonomy. So one person said, "I feel some places just treat people like pushovers just because I'm Black. I just get to the point where it's like I don't have a voice. I just have to do this, take art, because they say so. I don't own myself." That does not contribute to this person's desire to engage in the HIV care continuum. And then the fourth theme, I think this is the last one, the overemphasis on antiretroviral therapy can create a sense of dehumanization. So there's not so much of a focus on quality of life and co-occurring health and social issues in HIV care, and that contributes to poor engagement. I will say that healthcare providers, nurses, doctors, PAs, medical assistants, researchers, we are all in the same system. So this is not saying that HIV care providers are not doing their job. They are doing their job. But they're in a system where they have very short encounters, and they have a job to do, which is basically to get people on medication. So I don't blame them, but it does create issues. So this person said, and then that's what the doctor just kept drilling on the same issue. I'm like, does this guy know anything? He needs to see the bigger picture here. If you want to help someone, like I said, you've got to see the whole picture of what's going on with this person and the reason why they have waited this long to take antiretroviral therapy. There's got to be some other things that are going on that you're not asking these questions. You're focusing on one thing. It's very frustrating. One participant told us, like, I feel like a mouth existing just to put a pill in, and that, I'm more than that. So that was our study on using critical race theory, which I thought was a very useful lens to understand HIV care continuum engagement. And then Rob Freeman had another idea, and he said, I think we should examine people's long-term HIV survivorship through the lens of symbolic violence. And this was a qualitative paper, to which I said, what's that? Because honestly, I'd never heard of it. So he had, obviously. So symbolic violence is a type of internalized non-physical violence manifested in the power differential between social groups. Highlight social actions occur in a symbolic framework that is maintained by society. All right, so I'm very concrete in my thinking. This was very hard for me. But over the time that Rob and I and the team worked on this paper together, I did understand it. So the way it manifests, and I'll give you some concrete examples in a second, are communications, language, policies, the built environment. Some of these are reflected in the last paper that I mentioned. Surveillance mechanisms and violation of dignity and rights. Those are all examples of symbolic violence. So this is the result from our qualitative analysis. So for people living with HIV over the long term, so 10, 15, 20, even 30 years living with HIV, this is, and for low income people, people of color, this is a very, very common experience that they share. So symbolic violence is communicated. So for example, verbal and nonverbal communications, calling someone an addict, streetwalker. Policies that keep people in poverty, financial benefit levels. Poverty is a choice we make as a society. We do not need to have people in poverty. It would not be rocket science to not have people in poverty. Procedures and practices in healthcare settings that don't support autonomy, violation of dignity and rights. So participants will say they were drug tested without consent. And the surveillance mechanisms, so many. Supportive housing. These are grown people, and they're told, what they can and can't do, and when to come home, and who can visit, and what they can cook and what they can't cook. Probation, and then the built environment. So, if like you go to an HIV care setting in a affluent neighborhood, it has a fish tank, saltwater fish tank, and it has, again, there might be a coffee machine. And then if you go in a low-income neighborhood, you're yelling through plexiglass for someone who the participant says looks like she needs a vacation. But sadly, the violence is not only communicated, it's internalized. So what we found in our analysis is that people carry this violence. After 30 years of living with HIV, they get the message loud and clear, and that results in them feeling ground down, emotionally exhausted, a diminished sense of self-worth. I know you, society, are telling me I am worth nothing. I'm poor, I'm a person of color, and I have HIV. Maybe I am a substance user. I have got the message loud and clear. And then you hear about a loss of a will to live. So we're all about helping people make decisions, and we have a stance that antiretroviral therapy is their best chance for a long and healthy life. And we focus really exclusively on people not taking HIV medication. And then people will say to us, like, no, I don't care. Like, why should I live this life that you've created for me? Social isolation and self-isolation are part of this process, feeling dehumanized and devalued, internalized stigma, sensitivity of restricted autonomy, and self-blame for HIV failures. I just want to say this is the only paper that we worked on that I would cry while we worked on it. I actually feel emotional walking through this because I'm thinking about really what that experience would be like. So the internalized symbolic violence is a factor, and then we see alternating outcomes. So for many periods of time, people harness substantial effort. They recognize the effects of the symbolic violence, although I would say that they blame themselves and not necessarily the society for the most part, and that's very human. And they take medication for long periods of time or short periods of time. So I got to hand it to them. This is not easy to do. And then other times, symbolic violence and its effect can overwhelm resources and impede their engagement in care. And so they sort of alternate. And this paper kind of got us interested in what are the patterns of stopping and starting medication? We don't really know, if you've lived with HIV for 20 years, what the patterns. So we asked that question in a mixed methods study using a convergent parallel mixed methods design with Black and Latinx people living with HIV, not virally suppressed. This is part of a larger study. And they have extreme socioeconomic disadvantage. So we did quantitative work, the qualitative work, and then we integrated the results. So I'm going to tell you about the study without repeating any of the themes that came up in the other two studies. Okay. So what we asked, what were the multi-level factors associated with stopping and restarting antiretroviral therapy? How do they operate? This is a cross-sectional study where we can look retrospectively with our data. And then what multi-level factors are associated with persistence and how do they operate? But we called it stopping, starting, and sustaining the alliteration. So they were people who lived with HIV for 14 years, the range from 1 to 3. And they stopped and started a median of 5 times with a range of 0 to 300, 300 probably being an estimate. And then the longest duration of sustained antiretroviral therapy was 18 months, but it ranged from 0 to 7 months. So a lot of variability. And in our dependent variables, we controlled for the time since diagnosis. So this is actually a rate. I'm just going to summarize the results. So for the most part, stopping and starting antiretroviral therapy more times is bad. That's how we looked at it. I mean, you could probably think of cases where that's not the case, but for the most part, if you're stopping and starting a lot, that's not good. So what was associated with a lot of stops and starts? Being male, transgender identity, we know that there's a lot of barriers associated with that. Moderate to high risk cannabis use, did not expect that. And then stigma. Okay, so that kind of makes sense. And then what was associated with fewer stops and starts, which for the most part is good. Some cases it might be, for the most part it's good. While being older and more years since diagnosis. So people adapt to HIV, and that's good. And as we get older, we might be better at handling things. Whether they'd ever injected drugs in their life was associated with this good outcome. And then motivation for HIV care was associated with fewer starts. So that's interesting to me as an interventionist because that's a modifiable factor, but that's something that we can work with. In terms of staying on antiretroviral therapy, the longer you're on it is good. Yes, you want to be on it continuously. So that one's not controversial. So Latinx background, if you'd injected like in the last 6 months or were injecting in the past 6 months, that was related to this good outcome. And then again, motivation for medication, motivation for care. So this is interesting. Something's going on in the injection drug use space. So there's stereotypes of people who inject drugs are not good candidates for antiretroviral therapy, but there is a lot of literature that pushes back on that. First of all, if you inject daily, that's a very routinized behavior, and your antiretroviral therapy can be tagged onto that behavior. You can build a habit. And they are probably in settings that take a harm reduction approach that might be really good for figuring out your medication situation. So we're sort of interested in that. And of course, the modifiable factors we liked. And then shorter interval on antiretroviral therapy of your life, African-American, Black background, alcohol use, and social support, which usually you think social support is positive. In this case, it was related to the negative outcome, which might have to do with something about complexities of social networks, maybe in resource-constrained environments, or the fact that social support can be a double-edged sword if there's stigma. So in terms of the qualitative results, I wouldn't say any of the factors that relate to stopping and starting were new. They're all things that are in the literature that we know: substance use, housing, and material factors. But quality healthcare, so we're not going to get into those too much. But the qualitative analysis was really interesting to show us how barriers were experienced and how they work, their mechanisms. And then we also were attending to structural and institutional racism. So again, I'm not going to repeat anything that we already talked about. But one thing we haven't talked about yet too much is substance use in this population, and it's endemic. So almost everyone's had substance use problems in the past. People use substances while they're in our study, sometimes at hazardous levels, sometimes not at hazardous levels, but it's just a really big issue for them. They can't really talk to their providers about substance use. I think the assumption is the provider said, don't use substances and take medication, but life went on and it's more complicated than that. But we have a very big problem here in New York City, and I don't think we're the only other place, which is that we have pharmacies that buy antiretroviral therapy from clients. This is illegal. So someone goes to fill the prescriptions. They're like, okay, so they've overcome their distrust, the fear, stigma. It's such a pain to do it. You have to deal with the emotions of having HIV to do it. All right, I'm ready to do it. They go to the pharmacy and the pharmacy says, I'll give you $150 for your prescription. And we're human, like you have material needs. What are you going to say? So we're doing an analysis now, and and these people were randomly selected. I feel like almost all of them divert their antiretroviral therapy, which is what it's called. I am so incredibly angry and frustrated by this that I don't even know what to say. I read one transcript, the paper we're working on. This person had been off medication for several years, and he started taking it again, but this pharmacy was looming in the background, and he just didn't give us the sense that he, like any one of us, could say no. So I'm very angry about this. So a quote, I never went there to the HIV care setting high, but the fact is the healthcare provider, knew I was doing coke. She looked at me in a different way. You faced a lot of that. I was like, okay, well, since I can't come to the treatment, I'm not going to take medication. It discouraged me. I just stopped taking medication. So you're thinking, pharmacies buy antiretroviral therapy? Is that really a thing? Oh, yes, it is a thing. Here, U.S. attorney announces arrest of black market distributor, diverted HIV medications. Pharmacy king ran massive Medicaid fraud rate, buying back HIV medications. Yes, price goes up and down. But I'll tell you a terrible COVID story. One of our participants was home in the early days of COVID. The medication was being delivered to him. And when the person came to the door on his little e-bike, he said to the person at the door, the person living with HIV, I'll give you $100 if you don't take the medications. And so even in your own home, people will try to dissuade you from taking life-saving medications. All right, so another theme that we haven't talked about yet is experiences in healthcare. What I haven't said yet is they really like their HIV care providers by and large. Not the settings, not the system, but with the providers. And so when we think about distrust, it's very important to think about distrust of the healthcare setting and the providers separately. Give the providers a shout out. Here's one, my new doctor, she paid attention. She sat down with me initially and she asked me what my experiences were over the years, which I thought was very good because nobody ever starts from the beginning to really understand who you are. So that was a plus. And then just making sure that, I'm up on my care. If I don't go to an appointment, I get a phone call from my doctor, not the assistant, not the secretary, from the doctor herself. All right, so let's just talk a tiny little bit about COVID. I looked to see if there's any national data. There are some national data from this paper, and people living with HIV have a higher odds of COVID death and hospitalization than people who are not living with HIV. Lower odds of mild or moderate COVID. I don't think they get COVID at higher rates, but they have higher odds of worse outcomes. And that is related to their CD4 count. And the elevated odds were higher among older age groups, male, Black, African-American, Hispanic, or Latinx adults. So what is that saying? It's the same factors rooted in structural inequality and structural racism for the most part as we have in HIV. So here's a little blurry slide, but this was tweeted on World AIDS Day. As we enter the third year of the COVID pandemic, we also enter the fifth decade of the AIDS pandemic. The theme for this year's World AIDS Day is equality. It's especially important, these dual pandemics and optimism for the future. That's the same, any disease, any issue, anything, it's the same, rooted in these structural factors. But on the upside, there's so many lessons from HIV that can be applied to COVID. And we've been working on some COVID studies and feel just so excited that all the investment that's been made in HIV can now turn to this new public health problem. So there's seek, test, treat, and retain strategies. Those can be used. We know so much about testing from HIV that can be applied to COVID testing. We understand fear, distrust, vaccine hesitancy, same issues that we talked about with the fear and distrust and counter narratives. And then we are experts in intervention. So we have 2 COVID applications that we've written, one focused on testing and one focused on vaccination. So we'll see what happens with those. Wish us luck. So we have a really serious challenge here. We have low levels of sustained viral suppression, worse in Black and African American populations and Latinx populations than white populations. And it's been this way for decades. We haven't cracked it. So we have to keep persisting. So I'm going to talk to you about some work that we're doing that uses something called the multiphase optimization strategy. And I know some people in your center are using this method. And it's got a lot of, you can use the MOST framework to study implementation, probably to study policies, to intervene at the level of settings. Our interest is in individual people living with HIV. So we spend a lot of time trying to understand structural barriers and social barriers and how to address them, but from the perspective of individuals. I think the main reason we do it is that that's the thing that's most interesting to me. I think that upstream interventions, policy interventions, working at the level of structures is extremely important. But the work I'm going to talk about today, these intervention studies, are with individual people. So we'll talk about MOST. So before we talk about MOST, we'll sort of talk about the classical treatment package approach. And the classical approach is really important. It hasn't gone away. I'm actually working on R34 now that will use the classical approach. And what we do in the classical approach is we come up with intervention components from the literature and our pilot work, and we put them together and we test them. So this is a hypothetical example from a paper that Linda Collins, who was the original developer of MOST, wrote. So motivational interviewing, text messages, meditation, whatever. It goes together, and then we evaluate in a randomized controlled trial. So people ask Linda, what's wrong with this? She will always say nothing. But the randomized controlled trial can tell us certain things and it can't tell us certain things. So if you have a significant effect, you don't know which of those components are making positive contributions to the overall effect. And then you don't know whether the inclusion of one component has an impact on the effect of the other, or whether a component's contribution offsets its cost, because you only know about the package as a whole, and you don't know whether all the components are really needed. And one thing that Dr. Collins has really raised my awareness of in my own work with the classical approach, and I have done many randomized controlled trials of the classical approach, is that I think we're so focused on efficacy that we, unconsciously or not, pack our interventions with components. So they're probably a lot longer than they need to be, and maybe more complex than they need to be. And then that affects future scalability and uptake. We don't know how to make the intervention more effective. So what the randomized control trial tells us, so say you didn't get a significant effect. So we would say like it didn't work. You don't know whether any components are worth retaining. You don't know whether one component had a negative effect that offset the positive effects of others. You don't know what went wrong or how to do it better next time. And those don't move the field forward. So like one analogy is like intervention science really has not changed that much in 30 years. So we came out strong. We have a randomized control trial, and we're all this amazing work, but we haven't really innovated that much in intervention science. We're still doing randomized control trials of packaged interventions all these years later. It's sort of like the first car came on the road, the Model T or whatever. But actually, the first car was developed in Germany, so it wouldn't be a Model T, but you get the idea. And then we didn't change it, but that's not what happened. So what happened is the engineers changed the steering wheel. Engineers changed where you sat, innovation, innovation, innovation every year. And that's sort of the inspiration for the MOST framework, is that it's inspired by engineering. And the idea is that by breaking things up into parts and some other aspects of the model that we'll talk about, we can create better interventions. So here's a hypothetical example with these same components. So in the last one, we packaged them and tested them. But in MOST, you can do empirically based optimization. And there's different methods for that. There's factorial experiments, there's smart design, adaptive design. MOST is not just one thing, it's a framework. So in this model, we would test these 5 components. Say we tested them in a factorial design, which can be called a screening experiment. 3 of them seem to work well together, including their interactions, and they worked well enough that we would evaluate them in a randomized controlled trial. So you can see we dumped a few of them off along the way. The intervention is shorter, but we still want to evaluate it in the randomized controlled trial against an appropriate control. When you're doing a study in MOST, you come up with something called an optimization objective. And this is sort of, I think, where the engineering inspiration comes in. So you can create the best combination of components that cost X dollars to implement, $250, $1,000, whatever your setting will bear. It's actually a little hard to find that out, but as we've learned, but you can still set some kind of limit. Or one that takes X hours to implement. Say your setting can do an intervention that lasts 5 hours. Okay, so what's the best combination of components that I can do in 5 hours? Or you could come up with the best combination of components that has no inactive ingredients. That's Dr. Collins' least favorite one, just so you know. I don't think she thinks that takes advantage of optimization as well as good. Or the most cost-effective combination of components. So every study in the MOST framework has an optimization objective. So we are doing an optimization trial now, but I'll tell you where we started. This paper published in one of my absolute favorite journals, AIDS and Behavior, such a good journal. We did a classical approach and tested a packaged intervention with people living with HIV who were not virally supported. And this was our intervention, 3 intervention sessions, granted motivational interviewing, they had videos. A support partner joined the intervention for more long-term support. We did patient navigation, and then we had support groups co-led by successful staff. And then the navigation tried to do all these things: accompany to appointments, refer to counseling, and prepare the adherence environment, support adherence. Our main endpoint was viral load and viral load suppression. I'm not going to show the results of this, but we did have significant effects on viral load and viral load suppression, about a log reduction in viral load in this study. But before we went to the next step, which could have been a fully powered randomized control trial, we sort of evaluated our intervention along the lines of the MOST framework. So did we have effectiveness? Well, it was efficacy, but yes, we had medium to large effect sizes on biomarker outcomes. Certainly you can always do better. Did we have affordability, which is another of the criteria in MOST? Well, we don't know. We don't know who would pay or how much they would pay, and we don't know the cost of implementing it. Although you could find out the affordability of a packaged intervention just as well as components. Did we have scalability? Well, I fear maybe not great. So we had 3 sessions, patient navigation and groups. It's a lot. And then we had all these other things like the peer here and the support partner here. So scalability, it would be probably pretty typical for a behavioral intervention, but not short. And then did we have efficiency? Well, we have multiple components. we don't know which ones are active. It's probably not as efficient as it could be. So this is EASE: effectiveness, affordability, scalability, and efficiency. Dr. Collins very good on her acronyms and her mnemonics. So we could probably do better. So we decided to do an optimization trial, and we're going to do a screening experiment using a fractional factorial design to test components, individual components. So we basically broke up our intervention into 5 components. So when I first heard about MOST, it was a while ago actually, I didn't understand how you could break things into components. It didn't make sense to me as an interventionist because components relate to each other or they interact with each other. But the answer I would say now is I do understand it. And yes, they do relate to each other, and that MOST can handle that. And there's a lot of, I haven't really heard of too many problems that can't be addressed in this framework, although I think if you have like a peer-driven intervention, that can be a little tricky. But anyway, so these are our components: motivational interviewing sessions. So you saw that we had that before. The support partner didn't work out, so we dropped that. Pre-adherence skill building. This is habit formation. That was part of navigation, but it didn't get a lot of focus. Peer mentorship. So the peer was part of the intervention before, but then we pulled it out in its own intervention. Support groups. So we had support groups before, but the peer was involved in the support group. And then navigation. And then the nice thing about this is each component also speaks to its own set of mediators. And then you can get sort of a sense of how each component works. And then this is more in a conceptual pathway, and then we went down to viral load suppression. And the model you can see is grounded in the theory of triadic influence, which looks at individual, social, and structural factors, and also self-determination theory, which is the accepted theoretical underpinning of motivational interviewing. The components were grounded in an integrated conceptual model. We've been working on this for about a year, and you were the first people to see it. I don't know if you'd be excited to see it, but we're excited to present it to you. But this is a theoretical underpinning of the intervention components. And it's a model that integrates critical race theory. So we talked about that, centering the margins, looking at systemic racism, and emphasizing structural competence. Harm reduction, pragmatic approach that guides towards any positive change, but applying harm reduction not just to substance use, but to anything, to HIV. So there's harms associated with HIV. If you don't take medication, it can be harmful to yourself. You may transmit HIV to others. So harm reduction can apply to it just as well as substance use. And then self-determination theory, which emphasizes autonomy, competence, and relatedness. And then sort of like as a whole, the framework is strengths-based, builds trust, it's destigmatizing, and dignity enhancing. So if all goes well this weekend, we're going to finish our qualitative paper on how participants receive this model. So you can look for it in a journal soon. As we're going through it, Rob Freeman, who I mentioned before, pointed out something very important to me. I showed you one paper that rated interventions on cultural competency, but what is cultural competency? Providing care to clients with diverse values, beliefs, and behaviors. I don't really know if that's where the action is actually. I think it's necessary, but I don't think it's sufficient. Probably more important is structural competence. This is a concept from Metzel and Hansen. And structural competence is understanding that if you see something like poor adherence, it represents the downstream implications of a number of upstream decisions. So our goal in our model is to be structurally and culturally competent and have it be salient, not just culturally competent. In terms of the study, it's called Heart to Heart 2. We're coming to the tail end of it, but our optimization objective is most cost-effective combination of components. I actually hope to show you whether we have any today. I don't have it for you. I do apologize. But the next time we see each other, I will be able to tell you if we do. I think we probably do, is the short answer. And I would say that decision-making in most is a very, very active area of investigation. This is sort of where Linda's putting all her attention now, including considering multiple outcomes. We can consider HIV care, viral load, viral suppression, and quality of life as our outcomes. So this is going to be the obsession for the next 6 months. So in terms of preliminary results, I'm not going to give you actual results, but I can tell you this with absolute certainty that you get a lot from an optimization trial. You get your mediators. How did each component work? I'm going to tell you, it wasn't the way we hypothesized it would work at all. The mediator that I showed you on the little conceptual model, that's not the mediator that mediated, if it did at all. So that tells us our conceptual model needs to change. That is so good to know. We know that we have inactive components. We know we have poorly performing components. We also have productive interactions, and we have counterproductive interactions. For example, if people got motivational interviewing sessions and support groups, they tended to do worse than people who didn't get that combination. So that's something you would never know from a classical approach study. So there's just really interesting interactions in all these components that you want to know if there's counterproductive effects. And then we do know the cost per component. And the next time we talk, I'll be able to tell you a cost-effective combination of components. I'm pretty sure we do. So next steps. So this is MOST in a nutshell. I'm going to stop in 1 second because we're almost done. MOST has 3 phases. So MOST starts with preparation phase. We did this in the R34. We came up with a conceptual model. We did a pilot test. We identified our optimization objective. And then the second phase is the optimization trial, factorial experiment. It could be smart, micro-randomized, whatever. We did the fractional factorial experiment. And now we are here. Optimize intervention expected to be sufficiently effective. If yes, we can go to a randomized control. If not, actually, the arrow goes here to preparation. We probably go back to some combination of this together because we do know a lot about this population at this point. We could do another optimization trial. I actually think this is what we should do. I think we've learned tons about our mediators. We've learned about the counterproductive effects, but I'm not sure doing a randomized control trial is really the best use of science. If you take this engineering approach, wouldn't it be better to go back to another optimization trial and have the absolute best intervention you can before you evaluate it in a randomized control trial and then try to disseminate it? So reflecting today as we're doing, I would say that we can do better as a field. I think we can do better attending. We could do better with structural competency, and this includes myself. We can do better in understanding the causes of poor engagement along the HIV care continuum. This is a tweet that I saw the other day that I liked. Well, we've seen many advances in the way we medically treat people living with HIV. I've barely seen any advances in the way that we treat people living with HIV. And I think our work speaks to that, is trying to address that problem. Here's another quote from a participant that inspired the title of this talk. There's not that many places that you can feel human, because you've got to understand there are times you feel less than human, which is why a lot of people don't take their medication and everything, because they want to forget. They just want to be, I'm just normal. I'm like everybody else. So you don't take medication and you don't present to doctors. And then she or he says, truthfully, you're putting more people in jeopardy by taking medication. All right, real quick. I'm envisioning an environment in which we can end the HIV epidemic in 1 minute. It is all possible if we want to do it. First of all, people need sufficient income. It's not rocket science. We could do that. I mean, capitalism seems to want people to be in poverty, but it is not necessary. High quality housing. So not just housing, but high quality. A low stigma environment. Not easy. It's impossible to imagine. Social connectedness. Meaningful work, activities, and structure, that's stripped from people when they're living with HIV, often because of benefit levels. Easy access to care and ancillary services, dignity, affirming, autonomy, supportive services, and structurally competent anti-racist research and services. This is sort of where we're concentrating our effort on the services. I can't myself change policy, but I'm going to advocate it as well. And then in terms of what service settings can do, well, they can do better with substance use, autonomy supportive approaches, and a lot of the things we talked about today, and also just being involved in creation of services. Nothing about it without it. All right, so my team, hopefully some of them are on the call today so they can get acknowledged for all their amazing work, their insights, and hard work. And just want to acknowledge also our other team members and our funders. And thank you, that's all.
Thank you so very much, Dr. Gwadz. That was really, really, really amazing to listen to, and so many points I know really resonated with me, and align with, I think, similarly with the experiences that our team would support as well. And so I just really appreciate what you've done here, and that you were able to present today, and share all your amazing work with us. So I'm very grateful for that.
That's nice of you to say. Thank you.
Yeah. We have a few minutes for questions. If somebody, you can either raise your hand, or I think you can just unmute yourself and go ahead and speak up, or write something in the chat. I'll get us started. I know, oh, sorry, go ahead, Kim. Did you want to ask a question?
Sure. So this was a really great talk. It's kind of out of my area of expertise in terms of HIV, but I think the messages that you're giving about designing interventions and including these sort of structural racism constructs are really, go beyond just the topic of HIV. And one of the things that I was wondering about is, as we think about optimizing interventions, so much of developing an intervention is this creative process, right? Of creating videos or writing messages, and I'm wondering if some of the time the failure is not so much because of, our conceptual models, or, we're not including the right mediators, or whatever. I'm wondering if some of it is just kind of like the intervention pieces themselves and how well they were created. And so I'm wondering if you have any thoughts about that, or have you done any sort of post-qualitative work with your participants about kind of what they think of the intervention, what they liked and didn't like, sort of what spoke to them. I think this is an area where we really need, as sort of researchers, we really need to involve kind of creative people in kind of this design of these interventions and making them as good as they could be. So I'm just wondering if you have any thoughts about that general issue, and whether you've looked at that or done any kind of post-qualitative work with participants, kind of looking at, just the sort of how great the intervention itself is, not necessarily like from a conceptual perspective.
No, I agree with you. I think I think research is incredibly creative, and I think interventions are creative. And I want to say that in terms of like sort of your question you raised about, is it the messages, is it the videos? You could, test that in optimization trials. So like if you want to, you could kind of think about like your intervention as a pie, and how much are you going to cut it up? So you could have videos could be one of your components, or messages could be one of your components. And for us, we couldn't slice our pie too thinly because we had 5 components. But like if you're doing online work, you could have as many components as you wanted, because you could handle that. In terms of the qualitative, we do a lot of qualitative. We actually, the paper where I showed you the integrated conceptual model, that's a qualitative paper where we went to participants and we asked them, like, what did you, we know what we think we did. What did you hear from us? What did you take from us? And it actually was different than what we expected. So for example, people didn't necessarily experience individual components, but they experienced our general stance and our approach, which was the 3 circles, loud and clear. And that built so much trust between us, which is important given our difference in power and everything else. And they said was so different from anything that they had ever experienced in a clinical setting. So for example, they come in the door and they're like, do I have to take medication to be in the study? And Dow Sherpa, who's on this call, who was one of the first points of contact, would say, we totally respect your decision. Whatever you want to do, you can be in the study. And we respect your autonomy, basically. And so we are really interested in what they like. So like we had videos too. Did they like them? And what was they didn't like? So we're trying to unpack it. So I think the qualitative and the quantitative together are really essential to answer that question.
Other questions? Just raise your hand, or I have a question for you. I'm wondering your kind of like, if you step back for a second, kind of your general approach to managing a lot of the different things that you've mentioned in your talk, because I know that I go through this experience, and I know other researchers do, and I know people on my team feel this way too. So I'm wondering your thoughts on it. That, when we describe the context that we're working through, it can feel very overwhelming because we know there's so many broader factors that, policy and contextual and housing and income. I mean, you mentioned a lot of things that would take like considerable change in contextual environment to address. And then it feels like then they're like the things that we can do, like the social behavioral interventions that we can do. And a lot of times I know for me personally, I feel like there's what I know needs to be addressed. And then there are like considerable limitations to the types of interventions I can do because the problems I want to address are just such a magnitude larger than what we have access to. And so my sense from your talk is that, you likely experience that sentiment as well. And if so, I'm wondering, like, how do you process that kind of gap between the two?
Yeah, I think we're in the same boat. But I think I want to say this. I think we both, and anyone else who's in this boat with us, we should really be challenging ourselves to not keep doing our sort of individual level interventions without.
No, I agree.
So, like, for example, quality of housing. Like, you could theoretically do an intervention or work with the city to get higher quality housing. I mean, I haven't done that, but it's theoretically possible. I mean, I am a little frustrated. Like I'm proud of our work. Obviously, you can see that. This is my vocation. This is what gets me out of bed in the morning. But I am frustrated with not being able to change the larger context. I think we try to circumvent it. And at the end of the day, we have an individual living with HIV who may decide to take medication. I think that's really valuable, but I think I could do better with addressing these larger structural factors. So probably need better connections to health department, maybe policy people. But that said, I don't think we should stop doing what we're doing. I mean, they think 38% of social determinants of health are at the individual level. Someone still has to pick up a pill bottle, open it, or maybe go get a shot for a month or two. So we have to consider the individual. So I think we need to do better, probably on all fronts.
Yeah, no, that's a lot of times where I land too, and thinking that that addressing the multiple concerns will really require the cumulative efforts of many, many people. And, we wake up every day trying to do our parts, and we need a lot of people to do their parts to really comprehensively and meet the needs. Sorry, did I just hear Melanie?
Oh, I was going to say, in our study, I didn't say this, but 40% of our participants achieve viral suppression in our study. That's not nothing. That's health, and that's not transmitting to HIV to others, and that's
Absolutely
from the stress of their viral load going up. So
Absolutely.
value in it. But I guess, I don't want to be in my office crying when I read transcripts because what's society's so messed up. We have to do better.
Well, and I think too, you mentioned costing a little bit. Every costing analysis that I've been a part of, it's so cost efficient, the types of interventions that we develop relative to a lot of certainly relative to treating the course of HIV disease and biomedical interventions. And so that's, when you think of like bang for your buck, it's a no-brainer.
Right.
So, other questions? I'm sorry, I can't remember if you said you had to be out of here by 1:30. It's 1:33, so I'm just,
No, I'm okay. I have something to do.
okay. All right, so going once, going twice. If you have questions, just raise your hand or enter into chat. Okay, I think that's it. Again, I'm super grateful for you. It was a really great talk. Gave me a lot to think through and just made so many points that really, I think, would resonate with my whole team. So I don't know. It makes me feel better knowing when other people are going through similar similar approaches and similar concerns and similar successes. So I really appreciated your time today.
Thank you so much for the invitation. It was great to be with you. And my time.
Yeah, absolutely.
Happy day, everybody. Take care.
Thank you.